I'm Dr. Pre, and this is the Longevity Now podcast, where we distill insights from the frontier of longevity and preventive medicine to help anyone live healthier for longer. Hey, everybody. Welcome back to Longevity Now. I'm your host, Dr. Pre, here with Dr. Anthony Zampino, good friend and old colleague of mine. Really excited to chat with you, Dr. Zampino. How are you doing today?
Doing very good. Thank you. Yeah, good to be here.
Awesome. Want to introduce you really quickly. Dr. Zampino is a neurologist who specializes in neuromuscular medicine, and he practices at the university hospitals in Cleveland, sees patients both in the clinic and in the hospital setting. I've been pretty excited to talk to you because there's a lot of content these days now on health and longevity / preventive health, but you are an uber specialist. You do neuromuscular medicine. I don't see a lot out there in the content sphere in your specialization. And I think it's a very cool one. So I wanted to kick it off and ask you to maybe describe it really briefly, like what type of medicine you specialize in. And maybe you could jump into what got you interested in it and why you chose this branch.
Sure, thanks. Yeah, there is not very much information out in the popular sphere on my field. It is very specific. And, just generally, I got into neurology, so the, kind of medical diagnosis and treatment of neurological conditions, really as happenstance. I fell into it in medical school and found the brain and the nerves and the nervous system to be incredibly interesting and found myself in the field. And really the rest is history. But specifically, neuromuscular medicine is a fascinating kind of subgroup of neurology where we focus predominantly on the nerves and the muscle. So, after we've left the brain, really digging into diseases that affect the nerves, some of the spinal cord, and then the muscles themselves. And this is a very technical area, and there's a lot of nuance that goes into making the diagnosis, and can be incredibly fun and challenging field to work in. And we cover a broad spectrum, and if you could imagine that comes from everything from mundane and common problems like pinched nerves or carpal tunnel, which many people have, all the way to more rare and incredibly rare genetic disorders, muscular dystrophies, ALS, and terrible diseases like that. So it runs this huge spectrum of disease. So quite fascinating.
And
Field.
was it that complexity that drew you to it? Sort of like very much like solving a puzzle, it sounds like.
Yeah, absolutely. It's definitely a puzzle-like field. We take in lots of data. We do testing, which is rooted in electrophysiology. So we do a lot of technical type of diagnostics, and we have to interpret those. And we're looking at voltages of nerves and things, and looking at numbers, and very analytical process, which I enjoy a lot.
That's awesome. And can you describe some of the procedures you do? Or the main one, I'll tee it up for people, is called an EMG, an electromyogram. Hopefully I didn't get that wrong. But what does that look like? What is that process if somebody comes in and needs this procedure done? And then are there any other procedures that you do to help in your diagnoses?
Yes, EMG is our main diagnostic. It's electromyography, actually. And it's
Got
really
it.
a combination of two different things. We have nerve conduction studies that we perform, and then we have electromyography, which involves a needle. But basically, patients who have any kind of nerve problem or muscle disease, they'll come into our lab. We'll put little sticker electrodes on the skin and measure the electricity moving through the nerves. And we take a small needle and we place that into different muscles, and that's connected to the computer, and we can actually record the voltages and different parameters that are put off by the muscle and the nerve, and then we can analyze that and figure out what's going on.
So you could pinpoint if there's a segment of the nerve that's not working as well by seeing what's happening between 2 points.
Right. Yeah, we can look and see if the electrical signal is blocked somewhere, or if there's loss of nerve fibers, is there slowing down of nerve fibers, is there a sign of muscle inflammation, is there a sign, there's many different ways we can look at the data and come up with diagnoses.
Okay, super cool. And I know you are working mostly in muscles, but do you also look at sensory neurons, or are you mostly looking at motor neurons? And I should step back for the listeners at a very high level. You have nerves that are controlling your movement and nerves that control your sensation. Do you look at both?
We do, yeah. So we have techniques to look at both kinds. Can even get a sense of what might be happening in the spinal cord or brain sometimes, although that's not the focus of our study. So we can really see what's going on with all the different types of nerves, with a few caveats that we won't belabor here. Yeah.
Right, right. Wait, this is neuromuscular 101. So,
Absolutely.
and when you say you do EMGs and nerve conduction studies, what is it done in a different way, a nerve conduction study?
Yeah, that uses recording electrodes and electrical stimulators, or stimulating the nerve and kind of creating an artificial nerve impulse to then study. Where EMG, or the actual electromyography part, we're putting a needle into someone's muscle, we're having them move that muscle, and we're measuring the native electrical activity within that person's muscle.
So, do you need to insert anything into the nerve for a nerve conduction study, or is it done like non-invasively?
So that's non-invasive. So we wouldn't want to put a needle in someone's nerve. Okay, we actively try to avoid that. Okay, but we can record what's going on with the nerve from stimulating a distance away.
Got it. I see. And is that just done with like a patch, sort of like an EKG, or
Yeah,
what kind of?
be similar. Yeah, we have different types of recording devices, but in the simplest form would be like a patch like that. We have rings and discs and bars and different things depending on the nerve and the situation.
Got it. That's awesome. I didn't realize there's so much different types of hardware in the field.
Absolutely.
One question, a little bit out of left field, but it came to my mind. There's been a lot of interest, I think, in the longevity space. There's a lot of interest in new therapies. You hear a lot about peptides. There's interest in new tools. And one thing that people ask me about is transcranial TMS, transcranial magnetic stimulation for depression. And I wonder, is there any role in using magnetic fields in your field in neuromuscular medicine, with the idea of, okay, we alter the magnetic field that creates some kind of a current? Maybe it's too weak, maybe it doesn't make sense, but I'm just kind of curious if that's anything that's ever discussed or brought up.
Yes, sometimes we do take advantage of electricity or magnetism to treat patients. Some patients will, if some of your listeners have heard of a TENS unit, or a unit that's through the skin, and it's an electrical stimulation device that'll stimulate the nerve and then cause a nerve impulse and cause the nerve in the muscle to activate. And some people find relief from neuropathic pain from that. This can be used by physical therapists sometimes to try and get the muscle to contract when there's a nerve or muscle problem. There's on the spinal end of the world, there's spinal stimulators or devices that are implanted to change the electricity within the spinal cord. And then on the cutting edge, not really something that I do, but there's other folks that are working on neural interface devices to connect to one nerve and then connect to a computer, or to, say, someone with paralysis to be able to control their arm through their brain through a computer. So there's all kinds of different ways that we can, sort of get around the native function of the nerve, or use electricity and magnetism to change things.
That's awesome. Yeah, Neuralink, like Elon Musk's thing.
Yeah, like that. Yeah, exactly.
Cool, cool. Well, let's talk about the types of things that lead somebody to potentially show up in your clinic. And we're wanted to segment this between preventable neuromuscular disorders and those that are maybe a little less preventable, like the ALSs. And I thought it'd be helpful to go through, starting with really the most common one, which is diabetic neuropathy, because I think sometimes, for us in medicine and all the listeners who are in the healthcare field, you see a lot of really bad diabetes, but walking around, the YouTube longevity crowd may not be as exposed to how bad the disease can get. So maybe you could tell us a little bit more about diabetic neuropathy and kind of what you see and what message you want to put out there for folks.
Sure. Yeah. And one of the most common reasons for a patient to come see me is having some part of their body be numb or tingling. So that's one of my most common reasons for visit. And that can really run a gamut from anything. But one of the most common things is actually what we call peripheral neuropathy. When we say peripheral neuropathy, we're talking about a disorder of the nerve endings. So you could imagine to contrast that, if you were to have an injury, say someone hit your arm, hit your neck or something, and you damaged a nerve, that nerve could then develop neurological problems. You could develop neurological problems or neuropathy. But in patients with diabetes or other types of what we say metabolic disorders, or anything that changes the metabolism or changes the environment throughout the body, you can develop a disease of the nerve endings, the farthest end of the nerve, so hence peripheral for that word. And if you develop a peripheral neuropathy, then patients tend to develop numbness or tingling in the feet first, and then that sort of slowly crawls up the body, up in the leg, and then sometimes up in the hands. And diabetes is the #1 cause of peripheral neuropathy in the United States, and it's very common within people with diabetes. However, patients with diabetes can have other types of neurological problems too. More likely to get carpal tunnel, they're more likely to get pinched nerves, or more likely to have other unusual and rare nerve problems. But most commonly is the peripheral neuropathy. And this can be painful, can result in loss of sensation. People can lose their balance, they can fall. So it can be a pretty significant problem. And it's completely preventable is really the key here. And, having a healthy diet and maintaining appropriate blood sugars can completely avoid this problem altogether. And, once you're already down the road of, you have diabetes, you're starting to develop nerve injury, at that point, the process is already happening. So really getting ahead of that, not getting into that in that place in the first place is really ideal.
So if someone's a diabetic and they're having some numbness in their toes or some tingling in their toes, is it ever reversible to the point where they can go back to normal, or are you really just trying to make sure it doesn't get worse and spread?
Right. Our first goal is to prevent progression. But sometimes if patients are able to really stabilize their blood sugar or even really reverse their health, sometimes the neuropathy gets better over time. Okay. But, that's not everyone. And oftentimes patients are left with some amount of problem long term.
That makes sense. And I got to imagine a lot of the glucose control would fall on their primary care provider or their endocrinologist. These days, a lot of GLP-1 agonists like your Wegovy's and your Ozempics. Is there anything that is more specific to neuromuscular medicine that you would do for this type of a patient? Or are you really there to kind of diagnose the rare or maybe non-obvious diabetic neuropathies and then have their primary care help manage it?
Right. Usually, um, I don't see the diabetic neuropathy first. That always goes to primary care first. And, usually patients with more unusual or rare types of nerve problems come to see me. But when I do see a patient with diabetes, the first goal is to identify it, make sure there's no other thing going on, make sure we agree with the cause. Sometimes you can have more than one issue going on, and or more than one cause. And ultimately, the care for that patient for their diabetes falls with their diabetic specialist. There's still a lot of trials and studies ongoing about the best way to treat diabetic neuropathy. Should you use a GLP-1? Should it be recommended for all? Should you do this? Or there other drugs? Stay tuned. That's still an active question in the literature. But at this time, we kind of focus on diagnosis, understanding, and then treatment of pain or neuropathic pain as well.
That makes sense. Okay. Awesome. Let's talk about alcohol use. Also very common. I know a big cause of neuropathy. One question for you here is, does alcohol-related neuropathy show up similar to diabetic, where it really starts as very peripherally, like far away, like in the toes, or does it have a different pattern?
Yeah, it's very similar. Oftentimes they look identical. It's said to be a painful, more painful neuropathy. So the alcohol induced neuropathy is sometimes more painful at onset than a diabetic. But, again, there's a lot of variability between people, and, depending on your underlying physiology and genetic characteristics, one patient will have pain, the next patient won't. It's somewhat mysterious. But yeah, a lot of times, these two things coexist. So if you're diabetic and you drink a lot of alcohol, sometimes you can't tell which one's which. But both are contributing, and we have to address both.
That makes sense. And one thing as an aside, I'm curious, is it typically just pain or tingling or numbness? Or are there any strange symptoms where somebody might wonder, is this neuropathy or is something else going on, like hot, cold, or uh, what else do you kind of see that indicates to you that something's going on with the nerves?
Yeah, thanks for bringing that up. There are many, many other ways that someone could experience this. So, a common one is balance. So, not being able to feel your feet. So, doc, I close my eyes in the shower and I'm unsteady. I've got to hold the wall. Something like, or I have to sit down to soap up shampoo. They can't close their eyes without losing their balance. Or, sometimes, especially in the younger crowd, what we call autonomic dysfunction, or problem with the autonomic nerves. So the nerves that go to the heart, that control your heart rate, that go to your blood vessels, that control your blood pressure, that go to your GI tract, that go to your sexual organs. So sometimes one of the first signs may be, say, erectile dysfunction in a middle-aged man, or a patient who is getting dizzy and lightheaded every time they stand up and they have to sit back down, or someone with, terrible abdominal pain and nausea after eating. There could be gastroparesis or damage to the nerves of the to the stomach, and then it causes motility problems in the GI tract. So, neuropathy can come up in many places, not just numb feet. It really runs the entire body.
Interesting. And do we know why some of the, you said in younger people, often you'll see things like the balance issues or the autonomic dysfunction. Is there a theory as to why?
Um, just to clarify, so the balance, for example, is probably going to be more common in the older
Okay.
patients who've had it for longer. If the disease has been going on for a longer time. The autonomic problems are sometimes the subtle first sign. So someone who's earlier on in the disease and it goes undetected or not thought about. So sometimes, someone with mysterious symptoms or dizziness or GI problems or whatnot. Sometimes that's the first sign before tingling. Okay, but we don't know why one person gets tingling first and the other one has autonomic problem first. That varies from individuals.
Got it. Okay. So it's just because they are younger that they're earlier on the disease process, but it sometimes manifests in these different nerves that are not your standard like motor or sensory nerves. And it's primarily sensory nerves that you notice this in first, right? Not
That's
necessarily
right.
like, mhm.
So, it's, if your neuropathy goes on for a long time, yeah, it can start to affect the muscle, the nerve to the muscle. But if a patient starts off with weakness, so say weakness picking their legs up, or dragging their feet, or weakness in the hands, that's actually a red flag that there's something else going on. It's not just diabetes; it may be some other problem, and then that's the time to come see me.
Right. And that's often your like an ALS or a MS or something that's
Well, that's a whole
potentially.
other thing. But there's hundreds and hundreds of different potential diagnoses, and it gets very complicated. Um, I wouldn't jump right to ALS, especially if you have numb feet. Okay, that's not going to, ALS wouldn't really cause any numbness or anything like that. But there's many possibilities, and it really, again, runs this big spectrum all the way from, say, something common like a pinched nerve in your back, and yeah, all the way on that severe end. Um, something severe like ALS. But we always want to jump to the bad thing, but oftentimes it's not.
Yeah, no. I just was thinking motor neurons, but I'll stop.
Yeah.
I'll stop jumping to conclusions. Uh, no, thanks for
Yeah.
that overview. That's super helpful. When thinking about alcohol, one of the questions I had is how variable is the dose response? So, is it the case that some people might drink, you know, 12 beers a day for years and not get much neuropathy, whereas other people drink far less and end up with neuropathy? Or maybe I can ask a
Yeah.
different way. Is there like, have you seen any cases where people seem to not be drinking that much, but still end up with alcohol
Yeah.
related neuropathy?
Yeah. As we kind of alluded to earlier, there's a lot of variability between people, and it's not a one-to-one dose relationship for every person. And a lot of that comes down to your individual genetics and metabolism. So some people may have protective factors against, nerve damage, and others may have reasons that their nerves are more susceptible to metabolic injury. And the same thing happens in diabetes. So just having a blood sugar of X doesn't mean you'll have that two people with the same blood sugar of X will have the same level of neuropathy. That may be drastically different. And it may be that there are underlying characteristics, probably many, many different genes involved in that, likely lead to one person getting a nerve problem while the other one is spared.
Got it. That makes sense. So it's important to look out for, even if you don't feel like your diabetes is that bad or your alcohol use is that bad, that you never really know.
Right.
Okay, cool. Well, another one that is relatively common that we had talked about before is B12 deficiency. Now, in my practice and with the longevity crowd, I often find the opposite, where people are taking way too much B12 and it's, undetectable above 2000 on their blood work. Who do you normally see this in? What type of profile? And is there a different pattern of the neuropathy there compared to the alcoholic and diabetic, or is it the same?
Yeah, it sometimes overlaps. They can look similar in the beginning, okay, or at various stages, it can look very similar. One of the things that B12 deficiency does that, say a diabetic neuropathy wouldn't, is there can also be injury happening in the spinal cord itself. So patients can get signs of spinal cord problem. And a lot of times that's not discovered until you see a neurologist and someone puts that together. It's hard to know you have that problem. It can also cause cognitive problems. So it can cause brain fog, trouble thinking, memory problems. So it's kind of more widespread than just my feet are tingling. It's although it starts that way oftentimes, there's more to it potentially. And the patients with B12 deficiency, that runs the gamut as well. So you can have someone who's just dietary reasons they don't get enough of it. They have a B12 deficiency. Other patients, especially with the more severe deficiencies, maybe they have a GI problem. So they have inflammatory bowel disease and they can't absorb the B12, or say celiac disease or a stomach disorder. So, there's many reasons why someone might not be able to absorb the B12 and then they get a deficiency.
And what kind of diets tend to be more deficient in B12?
It's one where you are lacking either some protein source for B12. So the thing that everyone knows is, red meat, yeah, but it's in other meat too, and actually a lot of seafood too. And, shellfish has a lot of B12. Clams and mussels and things like that actually are an excellent source of B12. So even if you're not a red meat person, you can still find B12 out there naturally in food.
Got it. So a vegan or a vegetarian might be more likely to be deficient in B12.
Correct. So a vegan, someone who's not eating any meat or any animal product, they're going to need a supplement.
Got it. And if people supplement B12, whether they need to do it because of their diet or because of one of these GI issues, do they tend to be able to go back to normal functioning and normal levels?
Generally, sometimes people need injection. So if you're not absorbing, then you need to have an injection that bypass the GI tract. And hopefully with treatment, a lot of times people's nerve problems or cognitive problems can be reversed and they can get back to a more normal situation.
Got it. So it's not necessarily permanent damage in the same way that diabetics or alcohol
Yeah,
can
it
be.
can. Yeah, it
It
could
can
be.
be still.
Yeah, in the most severe case or long-standing, but generally speaking, a lot of patients can get better.
Got it. And this just came to my head, and you could tell me if it's dependent by patient. What are the levels of B12 that you like to see people at? Like what's kind of
Yeah,
your, because I see different ranges in different labs.
yes, there's some variability in the lab assay and lab assays, I should say, across the board. And there are situations where patients have a very convincing syndrome that fits with B12 deficiency, but let's say their actual number is 280 and the lab says the number is 250. Okay, well, it's technically normal, it's not red, but the patient has a very convincing syndrome, everything adds up. Well, that person probably has functionally a B12 deficiency, or they're deficient for what they need. And we can occasionally do additional testing, say testing of methylmalonic acid or homocysteine or these other markers, to kind of give additional evidence that there's some, dysmetabolism to strengthen our argument that that level needs to be higher. So I tend to start to get worried in the right patient, so someone with the right symptoms, when their level starts getting to 300. Okay, even if that's not red on the abnormal on the assay, that could still be abnormal for that person.
Got it. So you like to see it above 300, or at least that's when now you think someone's going to be more at risk of having the syndrome.
Right.
And everyone's different. These lab normal ranges they don't apply for every single person. So you defer to symptoms when it gets
Exactly.
closer to that point.
We have to make sure everything makes sense, things go together, the patient has the right symptoms and problems to fit the lab tests we're doing. If things don't add up, then you have to look for other things.
Got it. And are there any specific sensory or even, balance or, nerve findings that make you think B12, or is it still kind of general and you're going through a list of things?
Um, you can see balance problems as part of the spinal cord syndrome that happens, and that's oftentimes picked up on a physical exam. So when we're doing a neurologic exam, if I see a patient that sounds like a neuropathy, I go start examining them, and they have signs of you know things that don't fit with peripheral nerve problem, might fit with spinal cord or brain problem. Now all of a sudden I started thinking, oh, could this be B12 or something else that's affecting other parts of the body other than just nerve?
Got it. And do you ever see nerve issues when people have too much B12?
No, not generally. So, we don't want the level to be sky high. It's better to be in a more normal range. But there isn't a specific nerve or neuromuscular disorder from too much B12.
Got it. And I guess I'll ask you if you could just really quickly, what is the interplay between MMA, methylmalonic acid, and B12? Like, how are they related?
I see. So it's involved methylmalonic acid. Just another one of these tests we can do, but it's involved in the metabolism for B12. And if someone is B12 deficient, um, it prevents the metabolic pathway from moving forward, and then methylmalonic acid will start to build up in the body, and it's prevented from moving down its pathway, and you can detect that. Okay, so it's a marker of that
Got it.
problem with metabolism.
So if someone's having that B12 syndrome, but let's say their B12 is borderline low, like 280, 275, maybe you're not sure, you check the MMA, and if the MMA is high, that gives you more confidence that, okay, yeah, this is a B12 deficiency in this person.
Yeah, that's correct.
So the B12 helps process the MMA, and
Yeah.
got it. And okay, so one that we have talked about, and I've seen in a few patients myself, is B6. And in this case, you can have too much B6. Uh, could you tell us a little bit about the neuropathy that you see, if there's a specific pattern that makes you consider, oh, maybe this is like an excess of B6?
Yeah, B6 is an interesting one. It's not as common to have a neuropathy from B6 problem. And I say B6 problem because too little B6 is an issue. Too much B6 is an issue. So if you have deficiency, you can look like a whatever neuropathy, just like all the others. But in excess, so if you're getting too much B6, it's said to actually be able to inhibit its own metabolism and creates this a disordered state. And you can actually develop a more severe form of neuropathy. Okay, we're kind of moving towards a 201 course here. If you get neuropathies that don't follow the rules, it doesn't start in the feet and track up the legs slowly over years, it'll kind of hit arms and legs and make people unbalanced and not right, like right out of the gate. And it can be quite severe. Okay, so it's something that you don't want. Let's put it that way.
So it's less gradual. It can be, it's kind of
It
ramp up
can be
quickly.
faster, and it can affect larger areas of the body quickly. It can cause severe imbalance and problems with coordination, stuff like that.
And you mentioned when we talked about this in regards to a patient that you can get something called a gangliopathy. Could you explain what that is?
Right. So that's what I'm describing to you without using that term. But so a ganglionopathy also goes by the term sensory neuronopathy. So it's actually when you've damaged the cell body of the sensory nerve. So it lives all the way up back by the spine. And if you actually injure that part of the nerve, it can kind of kill off the entire sensory nerve, all the way from your spine all the way down to your leg or all the way down to your arm. And then this is how you get a more severe and, a more severe type of neuropathy that causes
Widespread.
more incoordination. Yeah, and sometimes it's patchy, arm and a leg or hands and legs, so it doesn't follow our typical rules. And it caused a lot of incoordination and trouble walking because of imbalance. It can be quite severe.
And your proprioception, like your
Exactly.
understanding of where your limb is in space.
Right, exactly.
Got it. So it's not just pain. And with B6, is this reversible when you have excess B6? Like if you bring the B6 levels down, do you see this often going back to normal?
Yeah, patients who have the severe type, that's actually quite rare. We don't run into that very often. And sometimes patients, it's unclear, are they going to get better or not? If they've done a lot of damage to their nerves, that may not recover. But generally, I'll see a lot of patients that are either low, they're deficient, and a supplement actually can help them get better, or someone who's like mildly elevated, a little bit too high, maybe they're on a supplement of B6, they're starting to get some nerve trouble. I tell them to stop, and sometimes within a few months, they start to feel better.
Outside of supplements, what other causes do you see of elevated B6?
Um, it's mainly supplements. It's in a lot of food. It's in meat products and other foods, quite widespread. But you got to get quite a bit to start to cause toxicity at that level. And so we're mainly seeing that in people who are taking a large supplement for B6. The other case is if some rare case where patients on certain antibiotic like isoniazid that may induce a neuropathy, but that's a very specific situation.
Right. Tuberculosis.
Yeah.
I remember that is typically when we are using that one. Why?
Yeah.
I've tried to look into this. Do you know why so many supplements have B6 in it? I mean, there's a lot of them that
Yeah.
added in, and not just 50 or 70% of your daily value. It'll be like 1,000% or 3,000%. Do you know
Yeah.
why that is?
Well, that's part of the B vitamin craze. It's B vitamins are good for your nerves, therefore more B vitamin is better. And although, yeah, it's true, if you have a B vitamin deficiency that can cause a neuropathy, the majority of people are okay. You get enough B vitamins, you don't need more. And I think some of that idea that more B whatever, especially in the case of B6, it's thought of as a water soluble, so the risk should be low, but actually it's not. There is risk to it. So again, not more is not always better. We want to have the right amount to do what we need.
Yeah, and I suspect we're going to see more of these elevated B6 levels, maybe not to the extent of having the toxicity and symptoms, but in my practice, which is relatively small, I've seen it a few times now, elevated levels. And I guess that kind of comes to the range. The range that I'm normally looking at is somewhere like, well, the bottom range I almost never see, but if I remember off the top of my head, it's something like 2.5 or 3. The upper range is closer to 25 or 26. But I'm curious where you like to see people's B6 levels.
There's no particular number. There's different uh, levels for different labs. There's very little standardization in that way. So you'll have to refer to whatever the test that you're doing, what is normal for that. Um, but the key here is you have to connect that to the clinical symptoms and what's going on with that patient. But if you do happen to catch someone who's asymptomatic, has a super high level, you do have to wonder, and they're on a B6 supplement. I mean, that's maybe a chance to maybe back off, maybe reduce the dose or whatnot, and see if you could get the level back and maybe prevent a problem down the road.
Yeah, that makes sense. I think in Quest, their range is something like 2.5 to, I want to say like 26 or 30 in that range. So a super high level for you then means whatever that lab says, if they're, like double the upper range or something like that.
Yeah, if you're several times the upper limit, then I'm very worried. And the right clinical situation, I become much more worried. If I just stumble upon it, but then again, uh, I'm not testing that unless I think the person has a problem. And so I don't get very many uh, patients who are asymptomatic with a high level. That's less common for me.
Yeah,
Due to
that
my
makes sense. And in my
yeah.
practice, I will first start and see what supplements people are on. And if there's more B6 than I like, then I go ahead and test it and say, okay, let's take a look here and see if it's worth switching. And, for what it's worth, I've never found a reason to start someone on a B6 supplement. That just so rare to see people low, because to your point, it's pretty common to get the vitamin just from a regular diet.
Yeah, usually in malnourished patients. So in rare, I may put a patient who has, again, GI disease or malnourished situation. They may end up on a B6.
Yeah, and one point on GI disease is this, typically the GI diseases where you're seeing these deficiencies, whether it's B12, B6, I'm sure others as well. Um, is it really that Crohn's, ulcerative colitis, celiac, like some kind of inflammation? Do you also see these types of deficiencies in patients who have had bariatric surgery?
Yeah, so bariatric surgery is the other big one. So anything that's really altering, the system, either the ability to create the proteins that are needed to absorb um, the vitamins, or actually changing the motility of the GI tract. So, gastric bypass, inflammatory bowel disease, celiac, um, pernicious anemia, which is a autoimmune condition, really, but affects B12 absorption. And there's others that I'm not thinking of now, but any of these things, or short gut, like someone had a surgery and they cut out a lot of their gut for whatever reason, those people are all going to be at risk. We want to be more attentive to the vitamins in those people.
And you mentioned GI motility. I know this is one of the ways that some of the GLPs work. Do you see, or have you yet seen any issues in people who are taking, long-term or high-dose semaglutide, Ozempic, or tirzepatide, or any of these?
Um, Not in the nutritional deficiency category. I think in my practice, we have encountered some patients who've had some nerve complications. So there's actually a recent series of patients published who developed kind of a form of nerve inflammation from the rapid weight loss and the rapid change in metabolism when starting a GLP-1. It's a hot area of research at the moment is, can this actually damage your nerves if you lose too much weight too fast? And I have a couple patients who do have this, and they've developed a very severe, painful nerve disorder that's caused weakness. So even something like this, is generally good, and GLP-1s are doing a lot for a lot of people, but has risks, and sometimes it can affect nerves too.
That's super interesting. Do you know if people who lost a lot of weight rapidly, say from bariatric surgery, have had a similar condition?
Yeah, and just generally, there's we call it cachectic amyotrophy, but basically you lose a lot of weight for whatever reason, your body's metabolism or nutrient intake changes dramatically, and you can actually develop inflammation or damage to the nerves that need the nutrients that suddenly has changed so rapidly.
Got it. So it could also be like cancer or something like that
Yeah,
could trigger it.
yeah, exactly.
That makes sense. Okay. Oh man, it's super interesting. So let's talk about another preventable one. I know this is a more esoteric one, but copper deficiency. I know that it can be, something that comes up in folks with bariatric surgery. Uh, what is the flavor of neuropathy you see in someone who's copper deficient?
Looks a lot like B12. Okay, so it's a mimic. Um, so sometimes when I have a patient that has a convincing story for B12 type problem, and I examine them, they'll look similar. So oftentimes I test B12 and copper together in the right patient. But the key there is that it tends to affect the spinal cord. So you tend to see signs of spinal cord findings when you examine a patient. Again, something that's the doctor would be picking up on during a physical examination.
Got
But
it.
yeah, go ahead.
No, no, sorry. But
Yeah, and it's again, usually a malabsorption type problem. And one of the more common things is actually zinc supplementation can cause the problem. So if you're taking a lot of zinc, zinc is actually involved in the uptake of copper and can actually prevent it from being absorbed and used appropriately. So someone who's taking a very high zinc supplement may actually be slowly inducing a copper deficiency, and then you end up in a situation that you're trying to avoid. The other way is kind of previously, they've changed these products, but in the cleaning stuff for dentures, they used to have a lot of zinc, and that would actually induce a copper deficiency in people with dentures. So, there's several ways that this could happen. But now, most often, it's either, again, a bariatric surgery or, say, someone who takes a lot of zinc is doing it.
Do you have a sense of like how much is a lot of zinc?
The exact number, again, this is going to depend on the individual. What does it actually take to cause a deficiency? And if you're several times the upper recommended limit, like say you're taking 100, 200, 500 milligrams a day, that's probably too much. It's putting you at risk.
Would you see that in their zinc levels and their zinc blood levels?
You could see the zinc level being high and then the copper levels being low.
Got it. Yeah, I wasn't sure if, your zinc levels will top off and there's some point where you don't absorb it, but it's still blocking the absorption of the copper.
Yeah, I'm not sure. You'd have to check me on that. I'm not sure if it tops off at a certain level.
Got it. Got it. Super interesting. Okay. And a more common one, carpal tunnel. We talked about this. There's many contexts for this, of course, and this one, pregnant women, people who are retaining fluid for any reason, overuse. Those are all common reasons. I wanted to ask you though, where do you most commonly see carpal tunnel? Like, are there any kind of unexpected risk factors that are perhaps interesting?
Yeah, a lot of people have carpal tunnel. Very, very common. And people can have it at different times in their life. But, you named a couple of good ones, good risk factors for it. But, people who have physical jobs, if you're using your hands a lot, you have a physical labor type job, or even a repetitive movement task type of job, you could get carpal tunnel. And then there's some people who get it for no apparent reason. And then, as we mentioned, people with diabetes are more likely to get it. So there's many reasons you might end up with carpal tunnel. And, luckily we have good ways of diagnosing it. It's easy to treat most of the time. The surgeries for carpal tunnel to actually correct the problem have gotten very good and are a quick outpatient procedure and usually take care of the problem for most patients. But, in the more mild phases, or someone has a little bit or mild carpal tunnel, sometimes something as simple as a brace can solve it, and some, correction of posture. I always say if you bend your wrist 90 degrees, well, now you're pinching your median nerve at 90 degrees, and you're going to give yourself carpal tunnel eventually. So, a common one is you're sleeping at night and you sleep on your hand like that. Well, guess what? You're going to be pinching your nerve. So it's good to sleep flat with your arms straight and your wrists straight. But the really bad, really severe, we always joke around that the construction workers have it worse than anyone else. But the people who like really use their hands, they can get some very severe carpal tunnel.
Amazon delivery folks,
Sure.
like a
Yeah.
modern
Absolutely.
day
Same. Yeah.
equivalent.
Yeah. Amazon. Yeah. Absolutely. That's physical work. That really does it.
And how about anabolic steroids? When we were talking before, you had mentioned that can also cause carpal tunnel. Like, how does that work? Or, why do anabolic steroids potentially do that?
Yeah. A lot of these steroids are, even a disease state in the body that is increasing steroid, or, other situations where a patient may be on hormonal therapy for whatever reason. You're changing the signal for tissue growth, and you may cause, hypertrophy or thickening of tissues that should not be thickened, and if you thicken the ligaments or increase the fluid content in certain regions, then you can end up with narrowing of the little canal, that, the little tunnel that the nerve needs to run through.
Got it. Got it. That makes sense. And that's, in pregnancy, similar pathway,
Exactly.
more estrogen, increase in the fluid content. And I'm sure the fluid increases tend to be more reversible than having a ligament grow, which might require surgery to fully take care of.
That's right.
Okay, awesome. Are there any other preventable ones that come to mind? We've kind of gone through a solid list here.
Yeah, absolutely. I think if you're eating a good diet, exercising, taking care of your body, you're avoiding diabetes, you're avoiding excessive alcohol intake, making sure that your vitamin intakes are appropriate and we're not overdoing it on problematic supplements. Then you're doing just about everything you can to prevent most of the routine neuromuscular problems. Of course, there's other things too that we didn't get into, but that's a great way to avoid these types of problems. Obviously, if you have a physical job or if that's the nature of your work, sometimes it's hard to get away from these wear and tear type problems, carpal tunnel, pinched nerves, sciatica, back pain, stuff like that. Sometimes that's part of life, but keeping a strong core, keeping a strong low back and spinal muscles, that can also help prevent those kinds of wear and tear type problems, keeping your posture good. These are all the major preventative measures.
Do you have recommendations from a neuromuscular doctor on what kind of chair someone should use? A desk chair?
Good question. No, I don't. Maybe I should have a recommendation, but I think one of the things, you can pinch your nerves, like for example, your ulnar nerve, which runs around your elbow. If you have a really hard armrest, you can pinch the nerve there. If you always have your arms bent, you can pinch nerves, so having arms outstretched, having padded cushions, those are all helpful.
Yeah. Yeah, that makes sense. One day we'll develop the perfect chair.
Yeah.
Although we'll see. I have a theory that the right way to do it is just to sit cross-legged, and you kind of move from these standard height desks to a near the ground desk. But I'm sure sitting in any position for hours and hours on end is going to cause problems, regardless of
That's right.
of where
Get
it
up
is.
and move. Yeah, get up and move if you can, and take a break and stretch out.
Yeah, yeah. That's right. No more vibe coding. People got to take breaks from that. Let's
Sure.
let's talk about some of the ones that are not at least traditionally thought to be preventable, and kind of some of the more scary ones. Maybe we could talk about ALS. Who should really be thinking about ALS? I know it's quite rare, but it does have some perhaps family history there. And if somebody is worried about it, what are kind of the first steps you would recommend they take?
Sure. ALS, scary diagnosis, kind of brings a lot of emotions up and makes people nervous. And it's a serious disease. Um, and unfortunately, at this point, one that we don't have a really robust treatment for. And, in essence, this disorder is a disease of what we call motor neurons. So you have a neuron that sits in your spinal cord, and that goes all the way down your arm or all the way down your leg and connects to muscle. And for whatever reason, in ALS, those neurons decide to die, and they degenerate, and you're left with weakness. Okay, and this eventually progresses and leads invariably to death, unfortunately, as the diaphragm shuts down, as all the bodily functions start to shut down. So it's a very serious disease. Now, a lot of people know about this condition, or they have family members who've had it, or friends, and it can, bring up anxiety if you're aware of the symptoms. Sometimes something as simple as muscle twitching may be the first signs of it. But I'll get several patients, a month who come to see me for that complaint. I have muscle twitches. Do I have ALS? Okay, and the majority of the time, the answer is no. So all people have muscle twitches. You're tired, fatigued, you didn't sleep enough, you had too much caffeine, you could get a muscle twitch. Okay, but if it becomes a pervasive problem where there's muscle twitches everywhere, and you're becoming weak in the hand, and you're starting to lose weight, okay, now all of a sudden that's more concerning. So whenever we have weakness that has no explanation, it's a painless weakness, that's the kind of thing that we're now worried about ALS potentially. But then there's other things too. So not everything fits that well. Now, if you have a family member or friend, let's say you have a family member who has ALS, and you're wondering, well, could I have inherited a gene that gives me ALS? Well, maybe. They say about 10% of ALS is genetic. The other 90% happens sporadically for, unclear reason. And, in that subgroup, so that select few, okay, if you have a family member who had ALS, most likely they had a sporadic form, if you play the odds. But, there's that 10% that maybe they have a gene that passed down to you. And those are becoming more relevant, especially now that there's a couple new treatments that are being investigated. We have one now FDA approved for a specific type of genetic ALS. It's still in the early days. It's very promising. There's good data about it. And we'll ultimately see those patients are still out there, and that long-term data will come in still. That's for a specific kind of ALS. We call it SOD, or superoxide dismutase ALS. And I think that's hopefully going to be the first of more treatments that'll be coming out in the future. But still, at this moment, it's been slow to get a good, robust treatment. But
is it recommend? Sorry, go ahead.
Yeah. If you do have family members with ALS, we tend not to test people or look into that until patients develop symptoms. And the reason is there's a good chance that you may not have the gene inherited, or that family member had a sporadic form. And then we go through a lot of anxiety and testing for nothing at the end of it. And then the other problem is, well, let's say you do have that genetic mutation and you have no symptoms. Well, you may not go on to develop ALS. It's not 100% guarantee, and now you'll be living with that knowledge. Okay. Now, you can make a case if you have a family member, your father or mother has superoxide dismutase, and you want to join the clinical trial for the pre-symptomatic. Okay, that's a different situation. That probably makes sense to do testing. But otherwise, we wait for patients to develop symptoms, and then we address it from there.
Got it. And superoxide dismutase, that's a separate condition. Is that correct?
It's under ALS. It's a specific genetic mutation within ALS that can go on to cause ALS.
I see. And this one is much more heritable. It's much more likely to be
this one's
passed
heritable,
on.
yeah. So this one can be passed on. Where 90% of ALS is not. It's this complex environmental life experience interplay, and we really can't pin a specific event to that's why you have ALS. Okay, there's associations that show up in the literature, and there's a lot of good literature about certain types of toxic exposure, or say lead exposure, or really one of the strongest ones, air pollution. Going and increasing your chance of having ALS. That's at a population level. And there's plenty of people that are exposed to air pollution that don't get ALS. So it's not a guarantee. We can't assign the causation.
Right. Are there any dietary factors or lifestyle factors that are associated with ALS? Of course, to your point, there could be a confounding variable that means that's not really the reason. But with a lot of these things, I find that it's probably not a bad idea to reduce air pollution risk, even if it's not directly related.
Right.
Any other factors that people can control that might influence ALS?
Yeah, there's nothing dietary to my knowledge. Lifestyle things, there's some evidence to suggest repeated head injury, repeat concussions may have an association. Uh, you know, Individuals in military service, and that may be due to again, unclear, is that from head injury, because those two variables go together. If you're in the military, you may be more likely to have head injury, contact sport, head injury, what's actually causing that association? So again, the research on this is still evolving. And again, there's yet to be definite causative links that we can understand.
Got it. That makes sense. Yeah, scary disease, quite well known here. I mean, everywhere, I'm sure, but the Lou Gehrig's disease, for folks who may have heard of that in that way. Um, and I think it's one of those things that's very striking when you see it affecting somebody. I think for that reason, it stays in the mind. And well, a lot of these neuromuscular diseases are that way. Maybe we could talk about another one, MS, multiple sclerosis, not purely muscular, but maybe you could describe what happens there, and similarly, who should be thinking about that, whether that's testing themselves early or keeping more of an eye out on it.
Yeah, of course. So interestingly, and it's very commonly thought of, kind of popularly as a neuromuscular problem, it's actually not. So believe it or not, multiple sclerosis is not within the neuromuscular subfield, and it's actually grown into its own subfield of neurology. So there's a neuroinflammation, neuroimmunology has evolved as its own field, and they specialize in the treatment of MS and multiple sclerosis, all this. But I still see patients with it all the time, and it's common enough that it's out there. And what happens here is there's inflammation occurring within the brain or the spinal cord. So again, we're exiting the nerve. So we've been talking a lot about nerves. We're now entering into the brain itself. And in this condition, the body's immune system becomes activated against itself, an autoimmune condition. And that causes inflammation within the brain or the spinal cord, leading to neurological problems. And, again, it's one of these things where, why does one person go on to develop it? It can where another person doesn't. It can be a bit mysterious. But the good news lately is that we have very effective treatments for this now, and there's many different options and different drugs and injectable drugs and oral pills and everything that can really reduce the likelihood of having attacks of the disease. The disease comes as attacks or relapses, usually. And that's when disability accumulates more. And being on one of these drugs can prevent further attacks and prevent further inflammation from going on in the background.
Got it. And is this one that tends to be genetic? Like if somebody has a family member with MS, should they get themselves tested or perhaps be more on the lookout for symptoms?
No, it's not a genetic disease, so you can't inherit MS. Okay, but if you have a lot of autoimmune disease in your family, okay, then it does increase the likelihood that you could also have an autoimmune condition.
And this could be any autoimmune disease. It could be rheumatoid arthritis or
Yeah,
Sjogren's or lupus or
absolutely,
psoriasis or celiac, any of the above.
absolutely. Any of these, increase the likelihood. Again, nothing one to one, but just generally speaking.
And then are there similarly any lifestyle factors that seem to be protective against MS?
I see. Well, from generally speaking, keeping a healthy lifestyle, maintaining a healthy diet, this is good just generally for everything. Avoiding smoking is huge, actually. So smoking is a major risk, cigarettes, okay, for development of MS. And also maintaining healthy vitamin D levels. So there's evidence about vitamin D and its involvement in the development of these conditions. And then there's the literature about EBV, or Epstein-Barr virus, commonly known as mono. And this has a relationship to MS. And some have gone on to say, could that even be part of the cause of it? And patients who are not exposed to EBV may, do not go on to have MS. And so there's an interesting relationship there. Again, not a one-to-one thing. There's millions and millions of people that are exposed to the virus and they do not have MS. Okay, so it's not a guarantee just because you've had that infection. All right, that's very important to know.
Right. Right. Okay, cool. And are there any other, like, let's call them less preventable neuromuscular diseases that you feel like are worth knowing about? I mean, one I think of as myasthenia gravis, because it is quite treatable, from my understanding. So that's nice. We're always joking in medicine that neurology is a lot of stuff that you can't do anything about. So there are some success stories. Are there any others, or perhaps myasthenia gravis, that you think are interesting for folks to know about?
Sure. Yeah, and it's definitely not true. We have lots of treatments in neurology, and we can get people better. Okay. There's lots of different examples of that. But yeah, myasthenia gravis is an interesting one. Rare disease, but there's people with it out there, and you'll encounter them from time to time. And we have a lot of great treatments now. So it's an autoimmune condition. Body basically develops antibodies that go and they attack the nerve muscle junction, or the neuromuscular junction. And it prevents the nerve from telling the muscle to move. So you develop weakness. Okay? So basically, a weakness of the arms can affect the muscles that make the eyes move. So you can get double vision, you get drooping of an eyelid, you have trouble swallowing, things like that. And it's not the first thing you would think of if you felt a little weak, but occasionally that's what's happening. And it's a very treatable condition. We can get people back to near normal or normal sometimes, and it's very rewarding to take care of patients with.
How do you treat it?
There's many different treatments now, many. You have to have a flow chart of all the different options, but kind of the bedrock is steroids, prednisone. It's kind of the age-old method. You use steroid, other immunosuppressing drugs to suppress the immune system and stop it from continuing. We also have this fun drug called pyridostigmine, which kind of juices up the neuromuscular junction and helps kind of overcome the problem, the block by the antibodies. But that's not a cure, but it does make people feel better. So we like to use it.
And I have a question for you on this one, because I have a patient who had a thymectomy for their myasthenia gravis, and this was done in another country. Is that something that is still done? And broadly, like, why would that help? Is that thought to just help with autoimmune diseases more generally?
Yeah, great question. So it's more specific to myasthenia gravis, and it's still a treatment that we do. So periodically, in the right patient, at the right age, in the right circumstance, we may elect to do a thymectomy, and that's a good treatment. The reason that works is in myasthenia gravis, the thymus actually becomes a secondary lymphoid organ. So there's now B cells, part of the immune system that make antibodies. They tend to come into the thymus, and there's some interaction that occurs with the T cells there. And they set up basically an inflammatory shop there and start to produce antibody. Okay. Not that that's the exclusive location of the disease. There's still those antibody producing cells outside of the thymus, but removing that kind of hotspot for disease activity can be very effective for treatment.
Got it. But then does that leave them at risk for infections or other diseases? Because now you've stopped the autoimmune attack on the neuromuscular junction, but are you handicapping your immune system more broadly by doing that?
Yeah, that's a hotly debated topic. But generally speaking, as you age, okay, the thymus starts to involute and becomes less functional and less important. By old age, it's not doing very much. At least we don't think it's doing very much. Okay, and we're usually diagnosing this condition in adults who have had the majority of their, childhood and young adulthood of a functional thymus producing well-seasoned T cells, and so it's thought to have less of an effect on your immune system than, say, if you were to remove the thymus of a child, that would be a problem. Okay, but we're talking about adults who've had time for their thymuses to mature.
Got it. Okay. So the thymus has served a lot of its function by the time you're thinking about removing it.
Correct.
Okay, super interesting. All right, one last question for you. And I, as an expert in neuromuscular medicine, if you have a friend who comes to you and says, "Hey, I've been getting this weird cramping in my calf or in my hand," what is sort of your first steps? And I say this because I have this question a lot with patients, and where I'll often go is like, all right, well, with calcium, magnesium, what are some of your electrolytes looking at? But I'm curious if that's also your approach.
So how much caffeine did you have today?
Okay. How much sleep did they get?
How are you sleeping? What's going on in your life? What are your stressors? Any big life changes? Sick? A lot of times there's something. And if it becomes a pervasive problem, that thing's twitching and just will not stop, okay, then we can start evaluating. Again, from my perspective, someone's coming to see me for an evaluation. It starts with a good exam. We're looking for weakness and signs of disease. We do some basic testing, electrolytes, calcium, muscle enzymes, things. Rarely ever give us the answer. Rarely we'll go on to do nerve testing like EMG. Again, usually doesn't give us an answer. And oftentimes we're left with just a benign muscle twitch, or what people call benign fasciculation. Just these twitches that happen to all of us. Sometimes can be the beginning of disease. Sometimes can just be part of life. And the things that are bad, a problem, they will eventually surface themselves. Kind of the day-to-day cramps of life and stress, they tend to vary with what's going on in your life and tend to go away.
Yeah, it's super interesting how difficult stress can be to not identify, but there's so many different manifestations of stress. And I see this a lot more in the longevity field and the preventive health field. But that's good to know that it's less likely to be, your magnesium levels or calcium levels, and more commonly just current life circumstances, because it is something that comes up a lot. And one of the hardest things to do is sleep more and be less stressed in modern life.
Absolutely. Yeah, absolutely.
Yeah, even if you're a neuromuscular doctor. So
Very true. Yeah.
with that, I will let you go. I really appreciate your time, Dr. Zampino. This was awesome. Thank you for sharing your knowledge with us, and really appreciate it. And we'll link to your profile in the show notes. I know you are backed up like months and months in terms of your clinic, but folks are up in the Cleveland area and they need a great neuromuscular doctor. I, of course, would love for them to see you because I know you do an excellent job.
Well, thank you. Thank you. We need more neurologists. There's not enough of us out there to go around.
We do. But slowly but surely we'll be getting there. Well, thanks again. And yeah, it was really awesome having you on.
Yeah, thank you for having me. This has been great.
All right. See you all later, everybody.